Question number 161, we've got a 30-year-old male who presents with sudden severe crampy right loin to groin pain with nausea and vomiting. Urinalysis reveals microscopic hematuria. Which of the following is the most likely diagnosis? So we've got the very characteristic loin to groin pain with the hematuria. It's only going to make us think of a ureteric stone. So it's really common. It's commoner in males, age 30 to 50. We've got lots of different types of stones. Could be calcium oxalate, which is the commonest. Got lots of risk factors like anatomical abnormalities, hypertension, gout, dehydration, metabolic disorders. Symptoms are the loin to groin pain. However, you can also get pyelonephritic-like pain or symptoms with the fever and rigor. You can also cause urinary obstruction, so it can get secondary urinary retention. Investigations, urinalysis, which you'd probably see positive for blood. You do your normal routine bloods, you do blood cultures if they're febrile, and you could do an X-ray to have a look at the stones, which 80% of stones are visible on. Or you do a CT-KUB. Management is sometimes you'd have conservative means of management, and other times you'd go for other therapies such as extracorporeal shockwave lithotripsy. You could go for percutaneous nephrolithotomies, or you could even go for nephrostomies if they are causing, the stones are causing acute renal failure and there's no other means. Question number 162, got a 45-year-old male who presents with frank hematuria. Other symptoms he's presented with are flank pain, he's hypertensive, and he's got blottable masses in his flanks. What is the most likely diagnosis? So the only one of these that produces all those symptoms, the hematuria, the hypertension, the flank pain, and having blottable kidneys in his flanks, is polycystic kidney disease. It would be the autosomal dominant variant in adults. The risk is they develop cysts in other places, particularly the liver. They're also prone to developing perianeurysms, colonic diverticuli, and renal cell carcinoma. So investigations is we'd usually do an ultrasound to detect it there. You do a CT or an MRI as well, and treatment is only supportive. Question number 163, we've got a 40-year-old male who's seen in A&E, and he was involved in a road traffic accident. You've seen some blood at the external urethral meatus and perineal bruising. What should you not do? So this, of course, is screaming to us that we shouldn't catheterize him because he's had a road traffic accident. He's got blood at the external urethral meatus and perineal bruising. So we've got two injuries, anterior and posterior urethral injuries. The anterior urethra is the bit that's distal to the membranous urethra, and the posterior injuries are the ones that are distal to that. Usually when you have the posterior injuries, they are secondary to blunt traumas such as road traffic accidents and falls. Anterior injuries are usually secondary to straddle injuries. So here we had the shouting out signs of perineal bruising and blood at the external meatus. Other signs that might lead you towards thinking that you've got urethral injury are when you do a DRE that you either can't feel the prostate or it's high riding. You should never, ever, 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 under any circumstances, try to catheterize them yourself. But indeed, you need to ask the help of your fellow colleagues, urologists, who probably perform a retrograde ureterogram, and they might prefer to do suprapubic catheterization with imaging. Question 164, we've got a 6-year-old boy who was deaf at birth, presents with hematuria, lethargy, malaise, and ankle swelling. He's got a urea of 25 and a creatinine of 500. Which of the following tubo-interstitial diseases is most likely? So here we've got young boy, deafness, okay? And then he's got some kind of renal issue, so it has to be Alport syndrome. So Yep, so you usually have the sensory neural deafness. You can develop pyelonephritis as a complication, renal failure, and treatment is usually dialysis up until they can get a renal transplant. Question 165, we've got a 4-year-old boy who presents with abdominal and joint pains. He had a chest infection a week ago. On examination, he's mildly pyrexial and there is a purpuric rash on the extensor surfaces of his limbs and buttocks. Which of the following is the most likely diagnosis? So we've got young boy, abdominal pain, joint pain. We've got the characteristic purpuric rash on his extensor surfaces of his limbs and buttocks. It has to be purpura. 𝕊𝕆ₛ𴄇 Okay, so it is an IgA vasculitis. It's usually in young boys, and you usually get the abdominal, the skin, and the renal manifestations. You usually have a preceding upper respiratory tract infection. You have high anti-streptolysin O titers in about half the patients. Sorry, excuse me. It is uncertain as to where it needs treating beyond symptom control. The nephropathy is usually treated supportively, and sometimes you can consider drugs such as azathioprine and plasmapheresis to prevent renal disease from progressing. Question 166, a 4-year-old boy presents with malaise, abdominal pain, and intermittent fevers. On examination, there is an abdominal mass and hematuria. Which of the following is the most likely diagnosis? So here we've got a young boy who's presented with the triad of abdominal pain, abdominal mass, hematuria. Makes us immediately think of Wilms nephroblastoma, which is the 5th most common pediatric malignancy, and it can be sporadic familial associated with Beckwith-Wiedemann syndrome or the WAGR syndromes. And like we said, it presents with at the mean age of 3.5 years with that triad. Therapy is multimodal. We usually go for surgery, radiotherapy, and chemotherapy. Question 167, a 35-year-old complains of a swelling in the right groin that descends into the scrotum, which can be reduced and controlled by pressure over the deep inguinal ring. Which of the following is most likely diagnosis? So this is pretty straightforward. It has to be an inguinal hernia because we've got a mass that's going into the scrotum and that's reducible. We've got 2 types of inguinal hernia, or what is a hernia to start with? It's intra-abdominal tissue through the abdominal wall where it's weak. It can be 2 types, indirect, direct. Direct is where it is medial to, depending on where it is in relation to the inferior epigastric artery. If it's medial, it's direct, and if it's lateral, it's indirect. So it's usually in males, and it's usually provoked by conditions such as constipation, coughing, lifting heavy things. And then means of treatment are 2. Usually it's a herniotomy in children and adults, which means cutting it out, or just repairing the wall, which would be in older age groups known as a herniorrhaphy. Complications are incarceration, obstruction, and strangulation. Question 168, we've got a 24-year-old IVDU who's been found collapsed. He's been in the same position for the last 24 hours. His right buttock and thigh muscle compartments tight and swollen. He's got a potassium of 7.9, good gosh, urea of 59, creatinine kinase of 16,000. What is the most likely cause of his failure? So we've got somebody who's been in one position for a very long time. He's hyperkalemic and he's showing acute renal failure. Can be none other than rhabdomyolysis. Yeah. So the means of treating that would be to fluid resuscitate, alkalize the urine, make sure that he isn't acidotic and that he doesn't have any electrolyte imbalances. We've managed the hyperkalemia obviously as well. Sometimes mannitol is advocated. We'd consider dialysis if the renal failure can't be managed, and we might, don't forget that this is all secondary to compartment syndrome, so we need to relieve the cause by doing an urgent fasciotomy. Question 169, we've got a 50-year-old male with advanced gastric carcinoma who presents with vague pains in his back for the last 4 months. He is hypertensive, his blood shows a urea of 10, creatinine of 110, ESR of 70, which is really raised, and a raised CRP of 60. He's had an intravenous urography, which shows bilateral hydronephrosis, and he's got the characteristic sign of his ureters coming together in the midline with a periaortic mass. Which of the following is the most likely cause of his urinary tract obstruction? So we've got someone who's known to have a cancer. When we've done an intravenous urogram, we've seen the two ureters together, which is very characteristic. It can't be anything other than retroperitoneal fibrosis. So retroperitoneal fibrosis is proliferation of fibrous tissue, usually over the surface of L4 and L5. It's common in 40 to 60-year-olds, and it usually happens when you have an autoimmune disease, you've got metastatic cancer, you're on certain drugs such as methyl-dopa or beta blockers. And then obviously when we've done an intravenous urography, we've seen the bilateral hydronephrosis with the drawing of the two ureters in the center. When we've done a CT or an MRI, we've seen periaortic mass. If we don't have severe urinary tract obstruction, which requires its own kind of surgery, then treatment is usually with steroids, tamoxifen, and azathioprine. Question 170, we've got an 87-year-old man who has dementia and chronic heart disease, who's been admitted with painless hematuria. He's catheterized, however, his creatinine is going up to 260. He has normal observations, he's a bit dehydrated, and he has a distended bladder. What is the next step in management? So we've got somebody who's got hematuria, which means he's passing lots and lots of clots, and now his creatinine is going up, which is showing us that he's getting some kind of acute kidney injury with a distended bladder, which means that most probably he's got a clot that's gone either into the catheter or is obstructing his urinary passages. So the first thing we need to do is flush the catheter with 50 ml of warm saline, aspirate, and only then, if that doesn't help, then we think about inserting a suprapubic catheter. If we were to immediately just remove the catheter and insert a new one, that wouldn't help because you might still have a clot somewhere in the urinary tract that you still haven't dislodged. Ultrasound wouldn't really help because we already know that he's got a distended bladder, so there is some kind of obstruction somewhere, and we'd only give a fluid challenge after we had done our flushing, and then that didn't work. A 25-year-old prima gravida, 16 weeks gestation, has complained of abdominal pain, nausea, vomiting. She's mildly pyrexial, which is really, really important as opposed to being full-blown pyrexial. She's got tenderness, rebound tenderness and guarding. She's got polymorphia, raised number of white cells with more than 80% of polymorphonuclear leukocytes. What's the most likely diagnosis? So this is shouting out to us that she's got acute appendicitis, which is actually the commonest non-obstructive cause of surgical emergencies in pregnancy. It particularly happens in the second trimester. And then symptoms are usually abdominal pain, which is usually in the right lower quadrant in the first trimester, umbilicus second trimester, and then it moves up further to the right upper quadrant in the third trimester. They usually have nausea, vomiting, fever, tachycardia. They usually have guarding, rebound tenderness, and they have Rothsing sign, which is when you press on the left side of the tummy. You get pain at McBurney's point on the right side of the tummy. Severe disease can occur when you have normal white cells count, and you can also see pyuria in 1/10 to 1/5 of the cases. So you always refer them for emergency surgery. Question number 172, we've got a 24-year-old primary-parous female at term is being assessed as to whether labour needs to be induced. Which of the following factors would you not take into account when you are assessing for cervical ripeness? So all of these are Bishop score, part of Bishop score, apart from cervical colour, which would help us to assess how close she is to, needing to actually spontaneously going into labour or predicting as to whether she'll need induction of labour. So Bishop score is comprised of 5 different bits, and they all score 0 to 2. Maximum score is 10. So they are abbreviated into PEDS, which is position of cervix, effacement of the cervix or length, dilatation, softness, and station of the fetus. If you have a score of less than 5, it means that you are unlikely to have spontaneous labour and will need induction. If you've got a score of 9 or more, that means that you will most likely spontaneously go into labour. And then when you have a really low Bishop score, that usually is indicative that your induction as well will most likely not be successful. Question number 173, we've got a 30-year-old female who complains of irregular periods. She's obese and hirsute. Which of the following is the most likely diagnosis? So young female, obese, irregular periods. She's got signs of hirsutism, so it can be none other than PCOS. So PCOS is diagnosed when you have 2 out of 3 criteria. First is polycystic ovaries, meaning that you've got 12 or more peripheral follicles, or you've got an increased ovarian volume of greater than 10 centimeters. If you're oligo or you have anovulation, i.e. irregular periods, and if you have clinical or biochemical signs of hyperandrogenism, such as being or having hirsutism. Principal features are obesity, anovulation, and the effects of androgenic hormones. You always have elevated luteinizing hormone with an increased luteinizing to follicle stimulating hormone. Testosterone is high, and then you do an ultrasound and you see that you've got 12 or more follicles, or you've got an increased ovarian volume. Management, so usually ask them to start with lifestyle management with the weight control and exercise. They usually go for medical management as well, such as metformin, clomiphene, which is the first agent which increases pregnancy rates. You can go for the contraceptive pill as well, the combined pill, and you can help treat the hirsutism with something called 𝕊𝕆₂, or you can treat it cosmetically with laser hair removal. Complications are they are at very high risk of developing endometrial carcinoma, type 2 diabetes, and gestational diabetes. Question 174, we've got a 40-year-old female who presents with loss of periods, headache, change in visual fields, and galactorrhea. This is a nice question because nothing can cause galactorrhea as well as increased effects of intracranial pressure apart from a prolactinoma. What is a prolactinoma? It's a pituitary hormone which secretes prolactin. It usually presents with a triad of oligoamenorrhea, infertility, and galactorrhea, which can be spontaneous or expressive. There are 2 types based on the size. It can be microprolactinoma, which is less than 10 millimeters, or macroprolactinoma, which is more than 10 millimeters. Question 175, we've got a 30-year-old female who complains of a fishy smell to her vaginal discharge, which is more noticeable following intercourse. Discharge has been sent to the lab where it has come back with clue cells. What is the most appropriate first line of treatment? So we've got a fishy vaginal discharge that's showing clue cells. It can be nothing other than bacterial vaginosis. Mainstay of treatment is orometronidazole for 1 week. Next question, question 176. We've got a 28-year-old female who has presented at 30 weeks of gestation with nausea, vomiting, anorexia, abdominal pain. jaundiced. So that's the difference between that first question that we had, that she wasn't jaundiced, and blood pressure is normal. Of course, because she's jaundiced, we're going to go and do our liver function tests, which show elevated ALT, AST. What is the most likely cause or diagnosis? It has to be acute fatty liver of pregnancy, which is actually a rare life-threatening complication. And the main treatment is prompt delivery of the fetus with supportive measures to stabilize the mother. Question 177, we've got a 30-year-old homosexual male who presents with pain on defecation. He denies any diarrhea, abdominal pain, or fever. 6 months ago, he develops traveler's diarrhea while on holiday in Mexico. On examination, he is afebrile and his abdomen is soft and non-tender. Inspection of his perianal area reveals a group of 5 clustered ulcers, which are adjacent to his anal orifice, extending into the anal canal. A rigid sigmoidoscopy reveals normal ꫰𝕰𝕃 𝕃 Which of the following is the most likely diagnosis? So I'm going to go for herpes, and the reason why we've gone for herpes is because you wouldn't expect to see cytomegalovirus unless you are immunosuppressed with something like HIV, and he doesn't appear to have HIV. We haven't gone for Neisseria because he doesn't have the mucopurulent discharge, and it would usually cause a proctitis. However, we didn't see anything when we did a rectosigmoidoscopy, or a sigmoidoscopy, sorry. We haven't gone for Shigella because Shigella would usually present with bloody diarrheas and mucoid scoops, and ulcerative colitis would not have a normal appearance to his sigmoidoscopy, and it probably wouldn't cause ulceration in the perineal region as well. So herpes is usually known to cause multiple ulcers as well, so that's something else that backs up our option of herpes infection. Question 178, we've got a 50-year-old female, comes to see you complaining of menopausal hot flushes. She's not keen on hormonal replacement therapy. Which of the following drugs would be most appropriate to prescribe for her hot flushes? So then we would go for citalopram, because usually we'd go for HRTs. If we can't go for HRTs, then we usually go for antidepressants. Nobody is sure actually why. Other medicinal sort of options could be clonidine, gabapentin, or lifestyle changes. 179, we have a 19-year-old female who attends her GP surgery complaining of deep left-sided pain. So it's deep, so we need to keep our eyes open for that bit. During sexual intercourse, which of the following is not a plausible explanation? So poor sexual stimulation would never ever cause deep dyspareunia sexual pain. So we've got 4 different types of dyspareunia. It could be superficial, deep, orgasmic, or postcoital. Poor sexual stimulation can only cause superficial dyspareunia. However, when it's deep, we always need to consider PID, sort of the more sinister causes like PID, endometriosis, adenomyosis, cervicitis, prolapsed ovaries in the pouch of Douglas, and a retroverted or retroflex uterus. Question 180, we have a 40-year-old female who is in week 24 of her pregnancy. She has complained of epigastric pain, vomiting, headache, visual disturbances. Her diastolic blood pressure is more than 90, and she has a proteinuria of +1 on her dipstick. So the only thing that this can be on this list is preeclampsia, because we've got hypertension in the second half of pregnancy, i.e. after 20 weeks. We've got a diastolic which is above 90. We have protein in the urine. We don't have seizures, so it can't be eclampsia. We don't have hemolysis, low platelets, and elevated liver enzymes to call it HELP syndrome. We don't have placental abruption, so there isn't any bleeding as their PV or anything like that. And it wouldn't be an acute pancreatitis with proteinuria and hypertension. So answer is preeclampsia.